Good afternoon, my name is Lissette Williams, and my topic is Pediatric Sleep Disorders. Sleep disorders in children, if confirmed by reproducible findings in a sleep laboratory, are not appreciably different from those occurring in adults. However, sleep problems defined as a sleep pattern that is unsatisfactory to the parent, child, or physician are far more common.
20 and 30% of children have difficulties falling or staying asleep. 2 to 4% of children have difficulties breathing at night, something which is known as obstructive sleep apnea. 80% of teens get.
In application in medicine, we have that the consequences of untreated sleep problems may include significant emotional, behavioral, and cognitive dysfunction. Childhood sleep disorders may be divided into three categories: dysomnias, parasomnias, and medical psychiatric disorders.
So many of the children have difficulty falling asleep at night, do so because there are a lot of distractions. They may be exposed to lots of light in the evening, which affects their internal clock and makes it more difficult for them to fall asleep. They may be watching a lot of television or on the internet or texting friends, just filling their evenings with distractions and making it difficult for them to settle down and relax. Many older children have very busy schedules, have a lot of extracurricular activities going on during the week, as well as lots of homework.
Parasomnias are sleep disorders characterized by abnormal polysomnography. They are episodic in nature and are a reflection of central nervous system immaturity.
Common parasomnias found in children are sleepwalking, sleep terrors, confusional arousals, and nightmares.
Night terror. The child suddenly sits bolt upright and screams and is inconsolable for up to 30 minutes before relaxing and falling back to sleep. Tachycardia, tachypnea, and other signs of full-fledged autonomic arousal are apparent. Night terrors usually occur in children 3 to 8 years of age.
Sleep terrors usually are the most extreme and dramatic of the parasomnias and can be distressing to the witness. Approximately 3% of children experience sleep terrors, primarily during the preschool and elementary school years.
The obstructive sleep apnea syndrome is thought to affect 1 to 3% of children. Symptoms include snoring, difficulty breathing during sleep, or mouth breathing during sleep. OSAS in children is frequently caused by adenotonsillar hypertrophy. Other causes include craniofacial abnormalities, obesity, and neuromuscular disease.
Apnea means without breath. If you have obstructive sleep apnea, you literally stop breathing while you're asleep. The apnea can last for a few seconds to a minute or more, and as many as hundreds of times during the night.
The advantage we have that there are treatments in cognitive behavioral therapy that are effective in treating a broad range of childhood behavioral sleep problems. Pharmacologic treatments of sleep disorders are not supported by adequate and significant empiric data. Tonsillectomy may be indicated for obstructive sleep apnea syndrome.
Sleep disorder, if it's a behavioral-based sleep disorder, then the treatment is usually to change the behaviors, to establish consistent rules and to maintain them, to work on the child's schedule, make sure the child's schedule is regular in order that her internal clock is synchronized with the external clock.
And the advantage we have complications. The consequences of untreated sleep problems may include significant emotional, behavioral, and cognitive dysfunction. Also, we have obstructive sleep apnea syndrome and narcolepsy.
Falling asleep, difficulties in staying asleep, difficulties in waking up in the morning, excessive daytime sleepiness, and finally problems which appear during the night, what I call things that go bump in the night, so difficulties breathing while sleeping, sleepwalking, sleep talking, night terrors.